Welcome to AMGA's Executive Pulse with Dr. Brian McDonough. Each episode brings you candid conversations with the leaders innovating in healthcare delivery. Healthcare moves fast, so don't miss a beat. Let's dive in.
Hello and welcome to Executive Pulse. I'm Dr. Brian McDonough, and today I have a very special guest, Dr. Khuram Ghumman. Dr. Ghumman is someone I've known for many years. We'll get into that in a few minutes, but from a leadership standpoint, he is the Associate Dean for Strategic Partnerships at the FrankH.NetterMDSchoolofMedicine School of Medicine at Quinnipiac University, and that only begins to scratch the surface. And before we get into all that, I want to welcome you to the program. Thanks for being here today.
Thanks, Brian.
You know, when I said that we're going to tell a story a little bit, let me explain what's going on, and I'll keep our two-shot here. Dr. Ghumman was one of my residents when I was associate director in a role at St. Francis Hospital in Wilmington, Delaware. He was doing his family medicine residency. Might I add, an excellent resident, great to work with. So good that when he graduated, we actually brought him on as junior faculty. Now, why do I tell you all these stories? Well, the reason I do is there's a reason, and it has to do with leadership. I was the associate director, and I don't know, somewhere about, I forget over time, but maybe during his third year residency, I moved to chairman of the department. As chairman of the department, of course, I had more decision-making, budgets, the different things we all do. And it was one of my first leadership positions. And Dr. Ghumman was an excellent physician, still is, but he was seeing a lot of patients. He was very productive. He was doing a great job. And several times over several years, he talked to me about wanting to have more leadership opportunities. I heard what he said. I thought about what he said, but I probably didn't think about it enough. Again, young leader, I don't know enough about what's good or bad as I'm going through it. You learn these things. And what I didn't do was cultivate that. And at a certain point, he said to me, I have an opportunity for another position. Now, I did know enough to be happy for him because you want people to grow. So I was happy that he had another position. But he left my department. He went to Connecticut. And that's normally where these stories end. They're lost to follow up. Well, not in the case of Dr. Ghumman. First of all, I like to keep in touch with my residents and see how they're doing, but it was hard not to notice what he's doing. So I'm going to flip it now to Dr. Ghumman from your perspective, because I think it's very important from a leadership standpoint for people who are leaders, especially young leaders, to hear these kind of stories about how you viewed what happened and then how you took it to the next level. So I'll ask you to pick it up there.
Thank you. Thanks, Brian. So I will say two things. I think it's always the culture that you grow up in the department at St. Francis in Delaware. Even though you in that chair role may have felt that you did not nurture my leadership desires, but I think you still helped me grow. And I still remember distinctly one day, during that time, as I was, planning and thinking of moving up to Connecticut, you said something that stuck with me. And I distinctly remember you said to me, I know you have the bug in you. You will work in policy world and leadership world. Never take your white jacket off. And I still remember that. So I do a lot of these other things where I'm part of the policy and, the changes that are happening in our clinical healthcare delivery systems, but I am still maintaining my white jacket because the best time of my day is still spent in that exam room. So thank you for that advice. And that journey has been ongoing since, but it started all at St. Francis under your guidance and leadership.
Well, that was very kind of you to say. And I do mean that. I think that I've always felt the most important job in any organization in healthcare is the role of the person providing care. That being said, there's a lot of other roles where people do amazing things, and sometimes you just can't keep that white coat on because the obligations become so strong. But I think all of us who care for patients and do that realize that. And it means a lot to me that, first of all, you heard what I said and you remember it. And I will tell you, in my own career, done the same thing. With TV, all these other opportunities, I never stopped seeing patients because I always felt that was at the core. And at least in my case, it always gives you perspective. I will tell you the other thing. I think that what happens is when you're a physician and you're a leader, as a leader, you can tend to think you're brilliant. You can tend to think you're so smart, but all you have to do is step into a clinical setting and realize the 20, 30, 40 things you don't know in one afternoon, and it humbles you. And I think that makes me a better leader over the years to know I'm not perfect, because all I have to do is get into an exam room and realize I'm not.
Well said. Agreed.
So let's talk more about your career. Enough about me. But your career, I mean, you actually have done some great things. I don't want to go through the whole thing, but as far as working with the medical society, at the medical school, things you've done, tell me a little bit about your career path and trajectory, and most importantly for our viewers and listeners, what you've learned over the years.
So once, I left, so my first role out of residency training was with the graduate medical education as the assistant program director at St. Francis. But once I left St. Francis for Connecticut, I joined a fully outpatient primary care corporate style large healthcare system practice. And right around the same time, the FrankH.NetterMDSchoolofMedicine School of Medicine was getting started. So I recruited to start the primary care clerkship at that school. And I've been one of the founding clerkship directors ever since, and I have evolved into different roles at the medical school. But my clinical role, being part of this large healthcare system, I soon realized there was something that was not how I had envisioned my clinical practice to evolve into. So I left that corporate style practice of medicine and joined an independent, physician-owned independent small practice, and I'm still part of that practice now, being a partner at that clinical practice. I learned about, no matter how we see the evolving healthcare systems in today's world, I think the focus has to be our patient. And I take pride in saying, like, I work for my patients, I report to my patients and nobody else. And I think that has to remain at the center of all what we do. All the healthcare delivery processes that we build, we have to maintain the focus on that patient, on that family. And the family medicine principles, all the 5 C's of the primary care, like family physician most of the time is the first point of contact. Maintaining the complex coordinated care in the context of their beliefs, culture, all the social determinants of health. I think that framework has provided me evolve into this patient-centered health care delivery. And then I bring the same mindset in my academic role. And in addition to training our undergraduate medical education medical students, they get to see some of these pieces of the puzzle. And as they train and go into the clinical world, they can maintain some of that focus on that one individual, that patient that they're caring for. Having said this, in the past maybe 10, 15 years, as you can certainly allude to, relate to, the healthcare delivery has evolved in different ways, where for different reasons, we can talk all day about some of those reasons. The delivery systems have gone through a series of consolidation over the past 15 years, and some of those processes and acquisitions and mergers were driven by external forces like regulatory bodies and a lot of the legislative changes that happened about 15, 20 years ago. So a lot of those external forces have changed some of the healthcare delivery that we do, in like delivery to the patients has been different in so many different ways. So I think having gone through some of that transition has helped me evolve into my own role and current positions that I'm working with.
That's a very interesting perspective, and you brought into the fact that things have changed over time. And as we talk, I want to talk a little bit about comments and thoughts you've made about the healthcare system. And it's a good point to bring this up. In fact, this is really any of the guests I have on Executive Pulse. People are speaking from their own opinions and experiences. So Dr. Ghumman or other physicians I interview and guests, they're not necessarily speaking on behalf of their organization. And, Dr. Ghumman has so many different organizations that he works with on a professional level. He obviously couldn't double check and triple and quadruple check, but he can talk about what he believes to be true and important. So you talked about these changes, and you're right. I mean, I got involved with health informatics at a certain point, and for a while I was a CMIO and a chief health informatics officer. And when I look back at a lot of those changes were made to maybe get medicine out of the cottage industry type of independent doctor to something that could be managed more easily by having records. Certainly there's advantages to having medical records in the sense that people can share records and get information, and that is huge. But also there's the ability to kind of control care and talk about it. Have you seen that aspect of it have a role from your perspective, teaching physicians, working in a practice, and also being in the academic setting?
Great question. So I think I'm going to break that into a couple pieces. So I'm an optimist. I'm going to start by saying this. I think change is an important piece of like our growth, professional growth, and all the things that we want to do in medicine has to evolve over time. Otherwise, things that we did 20 years ago, I do not want to write those handwritten prescriptions anymore. So there is a room and place for the evolution of the healthcare delivery systems. But I think in a lot of the challenges that we see now, I feel sometimes we miss the core central focus, which is our patient. A lot of our healthcare delivery now revolves around the reimbursements, the billing and coding, the efficiencies of the healthcare systems are needed. Standardization in healthcare delivery systems are needed, no denying. But we have to pause sometimes and look at those changes from the patient's perspective and also see which one of those change processes are helping the patient at the end, and how is that impacting the healthcare delivery physicians in that mix. So a lot of times, I think there is sometimes mismatch in the expectations from the COOs and the CMOs and the soldiers, the physicians who are front-facing with the patients. One example from primary care world that we can both relate to is the expectation for certain number of patients in a certain time slot. And we cannot predict every single patient encounter will be completed in a certain amount of time. So I think we have to leave some of that potential for the 80-20 rule. The 80% of the things could be consistent, but then having that 20% of the margin, 20% of the potential built in for changes accustomed to that practice in one physical location may be very different than another town 50 miles away. So we have to design the systems for that community with some standardization, absolutely, but having the focus towards the service to that community.
That's an excellent point you bring up. I actually think you're right. I think one of the things is, I use the example, it's not like McDonald's or Burger King where everything can look exactly the same.
Right.
Different communities think differently. In the market where I am, where you're talking about New Jersey, Pennsylvania, in particular, Philadelphia, Delaware, Wilmington, it's so different. Even if you go into the state of Wilmington, or state of Delaware, you'll have Wilmington, but then you have the rural areas. And
right.
Pennsylvania, you're in Philadelphia, but then you have rural area and you get to Pittsburgh. So everything is different, and the needs are different. One of the questions I wanted to ask you about is, and we've been following these for years, and maybe AI will help, but metrics that are measuring things. For instance, it's really important to measure high blood pressure and success treating high blood pressure. And that's something that's easily measured. But some of the other things that are measured, I think sometimes we have metrics just because they're easy to get out of the computer, and they might not necessarily be what make the most difference. From your perspective, again, as an academician and also as somebody who is on the front lines, where would you like to see that? Where would you like to see us use technology as it expands to improve care?
I think that's a great segue into the future where we can be. So your excellent point in having those metrics. So we all strive, we all try to do the best potential possible evidence-based medicine care delivery in our practices as possible. No question about it. But I think sometimes the physicians, the clinicians are very good at providing that care, but they may not be as good at documenting what they did for that patient. And in our world where the payers are looking at the claims data, so a lot of those, let's say, for example, the hypertension example that you use, if you don't drop those CPT2 codes, even though the blood pressure management, the A1C for diabetes management, all the metrics for the nephropathy screen, the retinopathy screens are completed, but if the claims were not submitted in a duly timely fashion to the payers, they may think it was not done. Now, this is where we can leverage technology. This is where things like AI could help, rather than having to document one thing in 5 different places. So the discrete data element could be transmitted to the payers for their claims recording. I think we have to modernize some of this piece of the documentation and transmission to the payers so they're all talking the same language. And the burden of this happening currently relies solely on the clinician in the clinical practice. I think that burden somehow needs to be removed. And these are some of these pieces where the technology could be very, very effectively used for the benefit of the better patient care, not only for the billing and the coding and the claims.
You're past president of the Connecticut State Medical Society, so you, I think, had 4,000 physicians in that group. When you get a large group like that, were you able to impact decision-making and care in that role? And how did you use that role to improve care for the patients in Connecticut and obviously from the bigger picture almost everywhere?
Absolutely. So I think we are in a very unique situation being in Connecticut. You know, we are Hartford being the insurance capital of US. So we are with a lot of our other partners who may also have vested interest in some of the policy changes. So we obviously have, there's the bills that we support and the bills that we oppose. And at the end of the day, a lot of those challenges are unique to clinical practice. A primary care physician may be facing a slightly different problem than an orthopedic surgeon, but there's some overarching challenges that we all face. One of the challenges that we've been facing in our state is the Medicaid reimbursement rates has been stagnant for many years. And there has been some bills that we supported on prior authorization and the administrative burden on clinical practice in general, and also specifically around the prior authorizations. And more recently, we have been working on I don't know if you heard about the down coding. There are some algorithms and AI dictated processes being put in place where some of those are impacting the clinical practice, and the down coding is impacting the financial revenues for the health systems and physician offices. So there have been common grounds where we were able to build coalition. So there's some challenges that are unique to organized medicine, and there are some challenges where it's impacting more on this specialty versus that. So we always have our legislative priorities for the year, and we build consensus from all our participating physician interests and associations to get to that legislative priority for that year. So it has been a fascinating learning experience for me, and I think we were able to accomplish, even though small, but few successes in that process.
This is AMGA Executive Pulse. I'm Dr. Brian McDonough, your host. And as you can see, we try to bring on top leaders and talk about all sorts of issues. And I think it's really important. If you have interest in being one of our guests, or perhaps telling us who might be an interesting guest, please feel free to reach reach out to us at AMGA. It's an opportunity to more or less have more voices in the room. And I hope you're enjoying this. Dr. Ghumman has so many different things he's done. One of the things I know that you've worked on is you've been with the National Board of Medical Examiners. You're now working with USMLE, looking at, I guess, test design and question design and those things. The reason I bring this up, and I'll talk from a standpoint of family medicine, but I'm sure there's a lot of different specialties. In family medicine now, I mean, in the years I've been here, we used to take a paper exam and we would take it in some big hotel with 10,000 of our best friends. And then 7 years later, we'd do it again. And 10 years later, we'd do it again. They've moved to something now, which I actually am a big fan of. I love it, which is very nerve-wracking, but 25 questions every 3 months where you have an opportunity to be tested, and you can do it from home. You can do it whatever. You can even do open book. You can actually use resources and try to do the best you can. They're tough questions, and you learn as you go. And the reason I say I'm a big fan is I love learning as I go, because all of a sudden I'm teaching young doctors and I'm kind of doing the same thing they're doing. And I'm saying, oh my gosh, and I'll think in my mind, oh, they just asked that question. That's important. As someone who is literally designing these things and looking at the future, I can only imagine if right now we're doing interactive questions, it isn't far from now where we're going to have interactive patients and all sorts of things like that. Where's it going?
So interesting. I think the American Academy of Family Physicians and the ABF from the American Board for Family Medicine has also paid attention to this evolution and change. So instead of the 10-year recertification, now it is shorter. Every 5 years, there is a 5-year cycle now. And as you mentioned, the one-day test option is still available. However, it is encouraged, and most diplomats choose to do those 25 questions each quarter. And that is more relevant, that is more timely, that is more engaging process than not being part of that process for long, and then all of a sudden you have to take this one-day test. So I think what you are asking for, where we are headed, I think the regurgitation of knowledge that we used to test at some point in the past will not be needed as much in future. And I think how we interact with the available information and build the knowledge and wisdom on top of that information is where we need to be focusing on. Because we live in a world where there's too much information, but how do we extract knowledge and what's the wisdom of it? Sometimes not doing something is the right answer. So I think, to your point, we are moving in that direction where application of the knowledge and the critical thinking piece is where we really need to hone in, because AI and algorithms and all these tools are available to us and augment our work. It shouldn't be like those tools should be working for that practicing physician, not the other way around.
You bring up something interesting. My role now, what I love to do clinically, I precept or supervise residents, and we are making sure we use open evidence or other resources while we're teaching. Because, I like to think I know a lot, but the reality is, the more you practice, like I said earlier, the more you realize what you don't know, but then you can work with the residents, and we're teaching them to use these tools, because I believe that will be the future. I mean, you're kind of foolish if you can't. I mean, I was trained in the days when we'd find an old book and we'd look for the one picture of a certain rash to compare. I mean, now you could literally do a search and you can break it down and have tons of images and compare. So, there's so many more resources.
Absolutely. And I think we need to utilize those resources for our benefit. And especially AI could be a great tool for someone like yourself who has experience. So you can pick up when the AI or the open evidence is hallucinating or not giving you that accurate information. The early career physicians may still want to be careful as they are learning through these processes, because you can pick up when the information may not be accurate because of having this experience. The early career physician may have a little bit of a challenge there, but I think in general, the technology is to our benefit and to our patients' benefit. The how we all worry about that is it is going to replace physicians. So I'm not sure if it's AI or technology in general is going to replace physicians, but it may replace those physicians who are not using the technology by physicians who are actively engaging and augmenting their skills by this technology.
You bring up several great points there. The first is the one you just made, which is something I learned when we were doing electronic medical records. The only constant is change. If you don't embrace change, you're left behind. So you need, but also to take advantage of it. You talk about hallucinating, and that's one of the things right now. I was speaking to an expert who, really heavily involved with AI and coding and all those different things. And they said to me, one of the things is artificial intelligence by its very nature wants to please. So they're going to please and come up with something the best they can. But that pleasing may not be reality. It could just be something to come up with an answer. And if you don't have that experience, you're going to fall prey to something that could be totally off the beaten track.
Absolutely. So we have to be very careful how we deploy these tools and how we, maintain that focus on the evidence-based medicine, which is relevant to my clinical practice in my community.
One of the great things about Executive Pulse as a program, and we got to design it the way we wanted to, but to talk about leaders, why they like being leaders in healthcare. And not just that, but maybe what they don't like about it. So tell me, in your career, I mean, we've touched on just 4 or 5 of your roles, and you have so many more. What do you like about what you're doing, and what are you disappointed about with what you're doing?
So I think, like I said earlier, I'm an optimist. I think there's always something that you can learn from whatever process that you're in. So my leadership philosophy is, I think if you have the right team, right tools, give them enough right amount of technology and time resource, there's hopefully you will get to where you want it to go. You may not know from the start what the finished product will look like, but if you as a leader have the vision and you bring these other pieces of the puzzle together, you will get to where you want it to go. But that path may be a little windy. The path may take a wrong turn, a left turn, but eventually if you get there, I think that's a success. Now, how you react and respond during that journey is, I think, very critical and very important. And bringing the right people on your bus, bringing that right talent, I think will help. And I can't remember where I read this, but someone, I really believe in that, to hire people for their attitude, not always for that skill. Skills they can learn, but if they have the right mindset, if they bring the right mindset to your organization's culture, I think you will gain those other skills to get to where you need to go as a collective team. If you are part of that process where everybody is rowing in the same direction, you'll get to where you need to go. Otherwise, you can flip it and you will all be struggling. So I think having the right mindset and cultivate that in your team will only help to get to that finish line.
What are you disappointed in, or you're at this point you want to beef up or think you'd like to do? Because obviously you're a mid-career as a leader, so it's not like you're reflecting back. You can change things. What would you change, or what don't you like when you see things?
So one of my, being a family physician, being a primary care physician, I would like us as, nationally if possible, but hopefully at least in the state of Connecticut, retweak some of the delivery of the primary care and how we fund that part of our healthcare delivery as a system. I think we fundamentally have to look at the value proposition for our patients, not just the healthcare system and the payer, the insurance companies. So we have to reconsider our value that we bring, and also the resources, the limited resources that we have. And biggest resource in healthcare delivery systems we have are our physicians, our nurses, our healthcare delivery personnel. So how do we manage the expectations from the patients, the expectations from the clinicians, and also maintaining the bigger picture of the rising cost of the healthcare delivery, at the same time providing the care that they need in a timely way, rather than having to go back and forth in the administrative, jigsaw puzzle? Can we simplify some of that payment model, at least to the primary care? I know it's you're like, come on, how are you going to do that? I understand it's a challenging process, but I think at the policy level, we have to test pilot some of these concepts at the state level before we can demonstrate the potential reliability and consistency to bring it nationally. So hoping at some point we can increase the spend on the primary care, not only increasing the spend, but also how we spend that in primary care delivery. So that is something that I would hope that we can, over the next decade, continue to work on and evolve over time. I was taught, I practice family medicine. Families first, medicine is next. So I think we all, as clinicians, as healthcare delivery leaders, we have to remember, who are we caring for? Those patients, those families. If we bring our focus to a better experience for our patients, I think other pieces will become a bit more clear, and we may tweak, redesign some of those delivery systems and delivery models when we see through from the patient's lens. So I would encourage us all to just also remember the patients, the people, the communities are the source of our every single day that we wake up and go to the exam room. So we need to be keeping them in center of our design process.
Thanks for what you're doing as a leader, and for what you're doing for the future of medicine and our young doctors, and for the patients you care for. And thank you for all you do.
Thank you so much, Brian. It's been a pleasure, and I can't thank you enough for all the training and all the vision that you and all the faculty have provided me. Thank you.
You've been watching Executive Pulse. You can join us on a regular basis. We love doing these programs. There's plenty of them. If you haven't seen them all, go back in the library. I guarantee you'll enjoy them, especially if you're on a long drive. Take a chance and listen. And certainly, like I said before, if you want to be part of AMGA's Executive Pulse, let us know. We'll take advantage of it, and we'll try to share your story as well. Thanks again for watching.
Thank you for joining us for Executive Pulse. This podcast is brought to you by AMGA. For more information, please visit amga.org.